to 3 millimeters subluxation, acute dislocation, recurrent dislocation, and chronic or habitual dislocations. During these dislocations, rupture of this medial patellofemoral ligament occur in 94% or more. What's this ligament? Maybe it's forgotten ligament. This medial patellofemoral ligament always exists, is in the same layer of the vastus medialis. Attachments are on patella upper 1/3, in the femur between medial epicondyle and adductor tubercle. They is responsible for patellar stability 60%, together with a lateral retinacle from other side. It's an isometric strength 208 newtons, and is most tight in the full extension and tight diminished with flexion. What is concept of treatment of patellar instability? Of course, good patellar tracking, because after acute patellar dislocation, we can receive 70% new dislocations, after recurrent up to 49%. Treatment for patellar instability could be conservative or surgical. Mainly conservative. We can talk about this later. Surgical is proximal realignment and distal realignment, or treatment of patella and on trochlea. What is main principle? It's correction of the knee pathology. This is one of our patients where is done after the recurrent dislocation MC3A procedure and proximal realignment according to INSAL, but we received a new dislocation. How to prevent it? This is a new possibility to do reconstruction of medial patellofemoral ligament, and in this case, distal realignment. It's written many surgical technique for reconstruction of medial patellofemoral ligament with quadriceps tendon and with hamstring tendons. This is technique what we used: stripping semitendinosus, one single parapatellar approach, 2 tunnels through patella, transcondylar tunnel, pulling semitendinosus tendon, and interference screw fixation in femur at 40 degree of flexion. We operated last 1.5 year, 18 patients. Age is 70.8 years, and follow-up is average 12.8 months. That was mainly recurrent dislocation, recurrent subluxation 4, chronic dislocation 4. We done like single procedure at 12, and MC3A at 4, longitudinal osteotomy less. We at 55% found patellar chondromalacia. And this is our result. We check of this patient at 3 and 6 months and of the end. Of course, functional tests like lateral shift ratio, apprehension test, and X-ray. No of these patients experienced patellar dislocation. Koala functional score rise from 75 to 86, and the Lisholm from 75 to 92. I show you 2-3 patients. This is chronic patellar dislocation, 12 years, girl, and this is arthroscopy. It's important to do before and after surgery, of course. You can see dislocated patella, and we done these 2 tunnels. It's known technique, and this interference screw. After surgery, you can see very good patellar tracking and X-ray. This is a 16 years girl with recurrent patellar dislocation and chondromalacia. We start with chondroplasty, After this, with this reconstruction of medial patellofemoral ligament, on the end of the procedure, you can see very good patellar checking. This is a case of, this is the same patient. You can see very easy tunnels where they are. That means it's no inside osteosynthetic material. This is patellar dysplasia. This is Wiberg 2 and dislocation. First, we start, after arthroscopy, we start with longitudinal patellar osteotomy to correct patellar dysplasia. After this, we can follow with the same technique for reconstruction of medial patellofemoral ligament. This is X-ray on the end of procedure. And when we are looking to the literature, we can see that is not so many group of patients, between 12 to 50 maybe. This koala score is usually improved, and there is, in this report, it's just a few redislocations. In conclusion, we can say that is medial patellofemoral ligament important anatomic structure. Usually, we start non-surgical treatment after acute dislocation, except if we realize that is chondral or osteochondral fracture. That is maybe answer for question before. Except high sport activity people. It's indicated for reconstruction medial patellofemoral ligament for recurrent and chronic dislocations. Relatively simply surgical procedure, minimal invasive, could be done single or in combination with other surgical procedures. You remember, it's important to do all correction or abnormalities what you found in a patellofemoral joint. And it's useful because it's possible to use before growth plate closing, because we have a great problem under age, under 14, for example. And these our first results are good. Thank you very much.
Thank you very much. Although we live a great distance apart, we have drawn similar conclusions, but are there questions from the audience?
Hi, very interesting talk. It's Vikas Khanduja from Cambridge, UK. I just want to have sort of find out surgically, how do you make sure that the ligament is isometric, and what's the tension that you leave in it when you're actually tightening it or you're putting the screws in? Because I find that difficult.
This is main problem. I agree with you. This main technical problem. Because we use basically two parts of ligament, because it's two tunnel in the patella. I think that is advantage, but it's very important to strengthen this ligament during flexion, because it's the most tight in 40 degree of flexion. Usually I tight in this position, but sometimes I have to repeat this procedure 2-3 times, because over correction it's very easy to done, and that is the reason that I stress that this arthroscopy control very important for that.
But isn't the normal ligament absolutely tight in extension? So if you're tightening it in 40 degrees of flexion, aren't you actually creating a stress riser? I do it dynamically, you know, but in this 40 degree, I prefer flexion of 40 degree, because you can easily receive hyper correction to medial part. And this position on 40 degree is originally
written in this original paper what I saw, what I show you, in 40 degree. I don't know if you have your experience.
No, that's what I struggle with this, and I do it dynamically as well, and I was hoping that you'd actually provide some pearls. Would you have something to add, Chad? How do you actually, do you dynamically assess it, or do you actually tighten it in one specific position of flexion or extension? How do you actually assess isometry and tension in that ligament when you're doing a surgical reconstruction?
We use the semitendinous tendon also, but with a dynamic tenodesis. We have time for one more quick question.
Jörn Kircher from Düsseldorf, Germany. Did I understand you right that you recommended that children or adolescents with open growth plates?
Yes. I think for these adolescents and children, it's very, very useful because can be done like single procedure. Because, for example, before I have experience personally with the Rugolde procedure, and often I received recurrency subluxation.
But the femoral growth plate is very near to the insertion side of the ligament, and you use the tenodesis screw. How often have you done that, and have you ever observed any disturbance in growth?
Yes, that's true. That have to be done in X-ray control, in epiphysis, femoral epiphysis, not in the growth plate, of course. I agree with you.
Thank you very much. Our next paper will be